Hello. Thank you very much for attending this and hopefully informative educational session entitled Individualized Management Strategies in Psoriatic Arthritis, Diagnostic and Treatment Considerations. This is a part of a live CME webcast series known as Talking PsA. It's supported via accreditation by Rush. It's being developed by Practice Point Communications and supported by an independent educational grant from Janssen and Novartis. My name is Philip Mease. I'm a rheumatologist based in Seattle. I work at Swedish Medical Center, which is part of a large healthcare system known as Providence St. Joseph Health, and also clinical professor at the University of Washington. And my disclosures are noted here. And I'm joined by my esteemed colleague, Joe Merola, who's an associate professor at Harvard. He has usually a whole bunch of other things listed after his name, but for some reason he is being more modest today. But one thing to note about Joe is he's a hyperachiever. He's not only boarded in rheumatology, but also boarded in dermatology. So is ideally positioned to be a commentator and teacher today. And his disclosures are noted.
Philip, I'm honored to be with you today for the program.
Thanks, Joe.
Thanks for the kind invitation.
You should be better able to recognize the clinical manifestations of psoriatic arthritis in patients with psoriasis and evaluate the benefits, but also the safety aspects of treatment approaches, and establish an approach to monitoring patients as they undergo treatment. So to start with, we're going to be focusing in this first case-based approach on talking about spine involvement or axial disease in patients with psoriatic arthritis, followed by discussion about comorbidities and role of combined clinics and integration of care. And Joe is in a particularly good position to discuss that because he helps coordinate a combined dermatology and rheumatology clinic at Harvard and is president of a group known as PACMAN, which is a national organization that's devoted to supporting and promoting these combined clinics. Our first case is a 42-year-old male who happens to be a university administrator who has a 6-year history of psoriatic arthritis and an 8-year history of psoriasis. He has polyarticular disease as a manifestation of his PsA, previously well controlled on a TNF inhibitor and methotrexate. He happens to be B27 positive. He's also a bit obese and is an occasional alcohol user. We have some x-rays because he's been complaining of some back pain, and the x-ray of his pelvis shows what we call unilateral grade 2 sacroiliitis. That means that on one of his sacroiliac joints, he has evidence of periarticular sclerosis, as well as possibly an erosion and a little bit of joint space narrowing at the SI joint. And the spinal MRI, including the pelvis aspect of the MRI, confirms these changes with bone edema showing up around the sacroiliac joints. And so what are we thinking about when we see these results? Well, for one thing, he doesn't quite make what we call New York modified criteria for ankylosing spondylitis. In order to do so, he would have had to have bilateral grade 2 sacroiliitis or unilateral grade 3 or grade 4, and grade 4 is complete ankylosis of the SI joint. So he's a little bit less than that, but not completely normal. One other comment I could make is that if you put 5 or 6 rheumatologists and 5 or 6 radiologists in a room with this person's x-rays, they would all disagree, with some saying, he has nothing, that's completely normal, and others saying, hey, I think he's got bilateral grade 2 sacroiliitis. So we're choosing unilateral here as sort of a compromise between all those voices in the room. And really, what is important here is the MRI positivity, which I think is more definitive. This raises the question, are there differences between axial PsA and ankylosing spondylitis? So we're going to be walking through a few points that do delineate differences between these two shades of axial disease in the spectrum of spondyloarthritis. And part of the reason for that is that a little later on, we're going to be coming across a conundrum about treatment approach, which may be different in axial PsA versus ankylosing spondylitis. Here we have a Venn diagram that shows that HLA-B27 is a common gene marker in the two conditions, present in about 85 to 90% of patients with ankylosing spondylitis, but only about 30% of patients with psoriatic arthritis. So there are lots of people with psoriatic spine disease who don't test positive for this particular gene marker. If we look at the array of other genes that are seen in PsA and ankylosing spondylitis, we see a lot of differences. So they really aren't exactly the same disease from a genetic point of view. And one of these, by the way, happens to be on the PsA side, HLA-B8. And one of the interesting things about this disease, this gene marker, is that it's about as prevalent as B27, seen in about 30% of patients. And when present, it's got a unique radiographic or imaging characteristic associated with it, and that is unilaterality of findings. So unilateral sacroiliac findings as opposed to bilateral, for example. There was an interesting series of observations from the Toronto PsA cohort that is run by Daphne Gladman and the Toronto axial spondyloarthritis cohort run by Rob Inman. These are long-term registries that have been seeing patients over the years. And what is noted here by Joy Feld, who was working with Daphne at the time, is that adult patients with psoriatic arthritis, somewhere around half of them end up having axial manifestations. So that's taking all comers. And then there are a substantial percentage who have just peripheral manifestations of psoriatic arthritis. Whereas by definition, all patients with ankylosing spondylitis will have spine involvement, and typically about 10% end up having psoriasis. So are these patients with ankylosing spondylitis and psoriasis, are these actually axial PsA in disguise, or are they truly ankylosing spondylitis patients with psoriasis? There's an interesting debate in that regard, and well, I'm not going to get too far into it, but this is what the characteristics of those populations showed. So what are some of the comparisons between these populations? So we know that patients with ankylosing spondylitis, with or without psoriasis, tend to be younger in presentation. They have back pain from the very beginning of their disease process. They are much higher HLA-B27 positive, as I mentioned earlier. They're much more likely to have answer positively questions about inflammatory back pain, such as the back pain gets better with activity, worse with rest. It wakes them in the middle of the night with pain, that sort of thing. They also tend to have worse activity measure scores, such as the Bath Ankylosing Spondylitis Disease Activity Index, the measurements of spinal motion, physician and patient global assessment, and so forth. Interestingly, one of the differences here noted is that patients with axial PsA tend to be receiving biologics more frequently. And that's partly because they have manifestations of peripheral disease first before they develop their axial disease. And so they've had a longer track record of being prescribed biologics because of their peripheral disease. The exact prevalence of axial PsA is a little bit unclear. We tend to say 40 to 50% of all patients with PsA, but that's partly because we don't have a good definition, and also because not all clinicians will look for evidence of axial disease. For example, careful MRI imaging of the sacroiliac joints and spine. The other conundrum is that since axial PsA begins to develop later in the career of a patient with PsA, so for example, they start having their PsA peripheral manifestations in their early 30s, it might be 8, 9, 10 years later that they develop axial manifestations. And then it becomes difficult to sort out how much is beginning the early stages of degenerative arthritis in their spine versus actually having immunologic inflammation as the reason for their spine pain. Does this matter? So the answer, at least from the Corona, now known as CORE-EVITAS, Psoriatic Arthritis SPA registry, is yes. If you look at patients who have psoriatic arthritis, who have spine involvement, they are worse in every way than patients who have psoriatic arthritis without spine involvement. They have worse skin disease, more nail involvement. Their joint counts are worse. They're less likely to be able to achieve minimal disease activity with treatment. Their spine scores are worse. Their CRP is higher. And so we can think of axial presentation as being a biomarker for more severe disease. Here is another data point from the Toronto cohort where we're seeing some more specific features, and we see that in the axial PsA group, at least unilateral grade 2 sacroiliitis is present in 45%, but that leaves a lot of patients without evidence of sacroiliitis. About a third of them fulfilled modified New York criteria for ankylosing spondylitis. Again, 2/3 without that evidence. So there's a lot that we still don't know in terms of characterizing these axial PsA patients. Do these patients progress over time and eventually gain more disease as manifest by radiologic damage? The answer is yes. But again, we don't have good long-term studies to address this. The Toronto cohort is really the main one. So we have to use our clinical judgment and sometimes base our judgment about their disease on the effect of treatment on spine symptoms. To try to sort some of this out, there is a very large and significant trial that's a collaboration between the GRAPPA organization and ASAS, the Spondyloarthritis organization, together to define and classify axial PsA. So we have just started this study. In fact, our center has enrolled the first 2 patients of the projected 400 patients that will be entered who have psoriatic arthritis, and we'll be characterizing the heck out of them to try to understand how to define and classify axial PsA. So with TNF inhibitors, all 5 of them are noted here. We've got good solid evidence about efficacy in treating ankylosing spondylitis, and with certolizumab, the category known as non-radiographic axial spondyloarthritis. in which patients may not have classic New York modified X-ray changes of the SI joints, but they do have MRI changes or positive B27 and a number of different spondyloarthritis features. There have been no trials of the TNF inhibitors dedicated to axial PsA, but we've got plenty of clinical experience as well as the ankylosing spondylitis trials to suggest that we get good effect from these medicines in axial PsA. How about other medicine classes? So there is a study post-hoc with ustekinumab of the Summit 1 and 2 trials. So in the Summit trials, these were the phase 3 registry trials for PsA. It turns out that they collected information from investigators on patients they thought had axial involvement from their disease. And they looked at measures like the BASDI score, which is a patient self-reported measure, six different items, which is used widely in measuring response to treatment in ankylosing spondylitis, for example. And in this particular set of trials, pooling these patients, the patients who had axial disease seemed to get better with ustekinumab. This contrasts with a study in ankylosing spondylitis done with ustekinumab, phase 3 trial in which there was no difference between placebo and ustekinumab. A little bit of a surprise because there had been not only this fledgling data in axial PsA, but also in an open label trial of ustekinumab in 20 patients conducted in Germany that appeared to show a positive response. And we were a little surprised, partly because IL-23 is upstream from IL-17. We know that IL-17 works well in ankylosing spondylitis. So what gives? Also, if you down toward the bottom of this slide, risankizumab, another IL-23, pure IL-23 inhibitor that attaches to the P19 subunit. It had a negative trial in ankylosing spondylitis as well, no difference from placebo. So at the time of these two trials being negative, we had editorials. I was asked to write one. Ian McGuinness in Europe was asked to write one, where we tried to opine why we thought that that IL-23 wasn't working. Maybe it had to do with something about differences in immunobiology at the spine, with IL-17 being a more prominent player immunobiologically. In any case, negative trials. However, a study with guselkumab gave us some interesting results. And if I can bring up this slide, what this highlights is a post hoc analysis of the pooled phase 3 trials, Discover 1 and 2, of guselkumab in psoriatic arthritis. And here, too, the investigators were asked, do you think your patient has axial PsA or not? The investigators thought that 30% did have axial PsA. Then there was even a stronger objective measure that was asked for, and that was to say, okay, that's fine. You think that they have axial PsA. We're now going to demand that the subject has X-ray or MRI evidence of sacroiliac changes consistent with sacroiliitis. We're going to up the ante and try to make this a more legitimate axial PsA group. So that was the group that was studied. And what was shown was everything improved with the two different doses of guselkumab, 150 milligrams or 300 milligrams. So even in the more objective measure, the ASDAS, which heavily weights the CRP, improvement, achievement of remission. So it threw some cold water on the notion that IL-23s don't work in the spine. With secukinumab and ixekizumab, we certainly have positive trials in both ankylosing spondylitis, but also non-radiographic axial spondyloarthritis. And we have the only trial dedicated to axial PsA, known as the Maximize trial, in which the 2 doses of secukinumab were tested against placebo and showed good benefit. 2/3 of the patients at week 12 achieving ASAS-20 response, and then also having improvement in the MRI scores in the 60% of patients that had a positive MRI in this study. We also have interesting information on ankylosing spondylitis with the JAK inhibitor class. Tofacitinib has a positive trial in AS, as does upadacitinib. We're awaiting word from the FDA about approval or not, but we're hoping for approval of these JAK inhibitors in ankylosing spondylitis. No axial PsA trial yet to speak about. Thank you for your attention on that section, and it's time now for our co-host here, Joe Merola, to take us forward.
Thanks so much, Philip. I am truly always honored and delighted to be with Philip on stage, as it were, a virtual stage. That was wonderful, and also a tough act to follow, I have to say. But I will attempt. And Philip, I may call you into the discussion as we go along, so don't go too far. I was tasked with our comorbidities section, and the comorbidities, as we'll review, are numerous among our patients with psoriatic disease, and so a hard topic to cover in a relatively short time. We'll focus on 1 or 2 relevant, hopefully, to your practice. And also as a focal point for some of our discussion. So this is a list, and not an exhaustive list, of the comorbidities that have been associated with psoriatic arthritis, with psoriatic disease. Again, we're not going to be able to focus on the full breadth, but just to point out at high level, cardiovascular disease, the metabolic syndrome, including diabetes, obesity, osteoporosis, inflammatory bowel disease, inflammatory eye disease, certain malignancies, liver and kidney disease, psychiatric comorbidities, central sensitization or fibromyalgia, pain syndrome, gout, and others. And I think, as we'll look at, these are not only are they potentially found at an increased coprevalence, in many cases part and linked to the pathogenesis of psoriatic disease, but in some cases the overlap or flare of some of these conditions may actually be challenging in the context of underlying psoriatic disease, as we will soon see. So we're going to start with this case, a 57-year-old male with a history of psoriatic arthritis and comorbidities. So this patient presents with big toe pain consistent with gout. So it sounds like we'll have to assume some of the diagnostic, the diagnosis is correct here as we go throughout. But it sounds like a case of podagra. And so a little bit more background. This patient has a 9-year history of psoriatic arthritis, which has presented mostly as polyarticular disease. The patient was well controlled on adalimumab as well as methotrexate, and has had infrequent episodes of gout in the past, usually controlled with cortisone injection. So we'll get a little bit more information here around consideration. So you'll note in the comorbidity section, the patient has chronic hyperuricemia, hypertension, and elevated creatinine, and elevated BMI, and occasional alcohol use, is a physician, but we won't hold that against him, and is married. And so, taking a pause, I would say, obviously, it's quite a high elevated creatinine if you're worried about this person being on methotrexate, but take that for a moment with a grain of salt. We have abnormal renal function, and this presentation. So let's dive a little bit deeper into this, because it turns out, in fact, that there are overlap, and I may I may have altered this a little bit in terms of what fits into the middle section of areas of overlap between comorbidities related to gout and those to psoriatic disease. But the point is there is an area of overlap, particularly around metabolic syndrome, obesity, type 2 diabetes, alcohol use, et cetera, in that space. And to that end, and I actually think this is quite interesting, I think the first is a paper that we did looking at claims data and as well as some local cohort data in Boston looking at the risk of gout in the context of psoriasis and psoriatic arthritis. And the reason I think this is so interesting and important clinically is that not only are they not mutually exclusive events, but in fact, there's an increased risk of gout with psoriasis, and you can see a markedly increased risk of gout. So the hazard ratio for psoriasis was about 1.7, almost twofold. The risk of gout in the context of psoriatic arthritis was nearly fivefold here. So not minor at all. And you can imagine a number of clinical scenarios where the differential diagnosis might include a gouty flare versus a flare of psoriatic arthritis, perhaps a monoarticular or oligoarticular particular flare of gout versus psoriatic arthritis. Of course, could be poly as well in established disease. So this was the first study is one that we looked at in the health professionals follow-up study. You can see some of the numbers. And then there have been other studies as well, sort of corroborating this association between hyperuricemia and psoriatic arthritis. The second study is interesting because it showed the association in the presence of skin psoriasis. And you'll see in a moment why that is a bit of an interesting concept, potentially pathogenically, which we'll come back to. And then this other study that PsA was threefold more frequent in gout patients than controls, again, sort of supporting that association. So why do I say the middle piece is a bit interesting? So I would say not exactly mainstream, but there have been some suggestions that in fact, perhaps, and Philip, I will call on you at the end of this for your thoughts, but this has been present for a while in the literature, this idea that perhaps the hyperuricemia isn't just a bystander or a comorbid player in the overlap of the patient who has metabolic syndrome and psoriatic disease, but in fact maybe in some ways pathogenic or modulating disease. It's been suggested, for example, that the hyperuricemia could be derived from keratinocyte turnover and in psoriatic disease, or as a from keratinocytes themselves. There's some idea that perhaps the MSU crystals themselves could be part of the inflammatory process and an auto-inflammatory process signaling through the inflammasome that may lead to some PsA, for example. So, and drive some of the cytokines that we see in psoriatic disease. So, again, I wouldn't say it's necessarily mainstream to our pathogenesis of psoriatic disease models, but there are some interesting potential ideas behind how this could maybe, have some interplay or effect modification on the disease. And there's an interesting paper in the reference, if anyone's interested on a little bit more of this background. I'm curious, Philip, have you heard any of these sort of concepts, or do you have any impressions as such?
No, in fact, quite frankly, I'm taking much more notice of this cartoon and appreciating it because I think this is a fascinating set of observations that you're making here. It raises the question, if the patient doesn't have gout, is there a level of hyperuricemia in a psoriasis patient that you would employ allopurinol?
It's a fascinating question. I'll tell you where it came to my attention, and I promise I won't belabor this. But I'm also delighted that you find this intriguing. Again, I say certainly not mainstream, so I wouldn't go give this lecture to the medical students in the pathogenesis of psoriatic disease. But when we put together that paper in ARD around the association between gout and psoriatic disease, when one's trying to flesh out their discussion, naturally you have to try to draw some links. And we kept coming across this in the literature. And so we did, insert some of that into our discussion. And anyhow, food for thought. It's also interesting when we think about these diseases on the autoinflammatory spectrum, signaling through inflammasomes and such, how, sort of an interesting concept anyway.
But you ducked my question.
Sorry. No.
It's allopurinol, yeah.
Excellent question. So I am not familiar with any literature that would suggest that the allopurinol would modulate the risk of the PsA or the hyperuricemia in the context of it would certainly modulate the hyperuricemia and PSO, but that it would decrease the risk of going on to develop PsA, which would be, I guess,
I'm not so much thinking of that as just if it's driving pathogenesis of PSO at all, whether or not it should be controlled a little bit better than running around at 10 or 11 or something like that.
I love it. I to be continued. But
okay.
So here's a fun. So that was a fun one. But so clinically, and Philip, I know that one of these cases, in fact, came from you. So I know that you have seen this. I would say it's not terribly infrequent every year that we have a couple of patients who really truly have both, and we're managing both. And so hopefully this resonates with the audience with regard to very clinically meaningful discussion. Again, for the rheumatologist tuning in, I would say many of these will be intuitive, but I think part of the point here in comparing the differences here between potential presentations of PsA and gout is that many are similar, which again, I think is reason for us to have in the back of our minds a differential diagnosis that could include PsA flare versus crystal disease, perhaps in certain presentations, very acute presentations. Even things that we think of as being fairly spondyloarthritis specific, like dactylitis, and I'm looking to Philip, to give me, honest, be the truth serum here as I speak. But there can be dactylitis-like presentations of crystal disease. I've certainly seen some of those. There certainly can be PsA involvement of, MTP, although I wouldn't say it's a particularly classical presentation. It can involve that joint. Whereas I think certainly axial manifestations would be certainly quite uncommon for crystal disease, although I think we've, all seen those, a case every once in a while at a state presentation of someone who has, atlantoaxial involvement of gout or something like that, very, very uncommon, of course. In any case, and B27 positivity, of course, not in any way that I know of pathogenetically associated, but can overlap, with crystal disease as such. So moving our case forward, this particular patient who we saw had markedly elevated creatinine on the earlier slide, here, in fact, undergoes renal transplant. So this patient has progressive chronic renal insufficiency, necessitating transplant. And I have had this scenario as well. And I know that, again, I'm not outing Philip, but this was one of his cases. And I similarly have had cases of patients who have been status post-transplant and frankly are erythrodermic with their psoriasis or have bad psoriatic arthritis. And this can be a real challenging discussion to have with the nephrologist, with the transplant team around how do we manage disease. And so in this particular case, the patient was on maintenance immunosuppressive therapy for their transplant. And the nephrologist, which may consist, of course, of drugs such as tacrolimus and others, the nephrologist recommends against continuing the biologic. You'll remember this patient was on adalimumab a few slides back for treatment of psoriatic arthritis due to post-transplant infection risk, which, of course, we would share that concern. And the methotrexate monotherapy here is continued. The patient is noted to have chronic, again, we know about the comorbidities, the chronic hyperuricemia, et cetera, that we talked about on the last slide. And so the question is, how would we go about treating this patient who has ongoing joint symptoms? And this is a particularly interesting plot twist. So the patient, you see, presents to the orthopedist about 3 months later with this incapacitating midfoot pain on the right side. The patient also complains of some worsening polyarticulate pain, so at other sites, distal sites, as well as ongoing psoriasis. So some imaging is done in that context. An X-ray is unremarkable. And an MRI is performed, which shows erosive changes in bone of the mid-tarsal area of the foot. And the radiologist indicates that this is most consistent with gout. I'll pause for a moment because I have to say, I think it's interesting that we so many times have to have our own interpretation and contextualize our radiology reports. I think in Philip's very first case that we talked about, that was true around the sacroiliitis and the interpretation of the radiologist there. I find that even in my psoriatic arthritis patients in the conduct of diagnosing and working up their disease, often degenerative changes are mentioned or normal X-rays are noted. And sometimes when we go back and give them more contextual discussion or sit with the radiologist, in fact, they're able to tell us, yes, these are psoriatic arthritis changes, for example. And I think similarly here. So, clinically most consistent with gout, in consultation, bringing the team together, and maybe this team concept might resonate again at the end of our conversation around combined clinics and facilitate discussion among providers. Given the emerging symptoms of uncontrolled psoriatic arthritis and a near normal uric acid concentration in this patient, the radiologist recommends re-imaging using a novel imaging modality. And I know from conversations in preparation for our meeting today, both Philip and I have access to this dual energy CT modality. And I'd love to hear certainly, from the audience, if there's time at the end, if you've had experience with this. We've found this remarkably helpful of late, particularly in joints that maybe are less easily tapped or in other scenarios such as this. And in fact, in this particular case, it was wildly helpful because on the dual energy CT, you can see here that the results were that this was negative for crystal deposition, so really countering that gouty change suggestion by the radiologist, and in fact that this was all most consistent with psoriatic arthritis. I'm going to pause but for 10 seconds because this was Philip's case. And Philip, this is a really big turn of events for this patient, in fact, in terms of therapeutic intervention.
Very much so. And both the patient and I then turned to the nephrologist after the radiologist somewhat sheepishly amended his earlier report. And he said, Phil, I apologize. I was just going with what I thought was the more likely clinical scenario in my earlier report. But then he reversed and said, I think this is progressive psoriatic erosive disease. And so both the patient and I turned to the nephrologist and said, please let us use a biologic here. We'll just be careful as can be about infection. And the nephrologist relented, and the patient ended up going on a biologic and doing much better with resolution of the foot pain, being able to walk, and much happier camper.
Wonderful. I have to tell you, I've used this as well I had a young patient recently who in fact turned out to have polyarticular CPPD and a hemochromatosis that was diagnosed on dual energy CT of joints that we wouldn't otherwise be tapping.
Oh, interesting. Yeah.
So it's really a nice modality. So thank you for sharing this case. It's wonderful. There's a lot here and we have limited time as predicted, but I'm going to cover at high level a little bit about what we know about infection risk with these agents. And I think with this slide, although wordy, I think the slide here, the overarching theme is that we have a limited really data set to look at safety in the real world in the scenarios such as this, particularly in this scenario where we have a patient with renal transplant on immunosuppression. So, we extrapolate what we know from clinical trials, from meta-analyses of clinical trials data around safety, and then from real-world evidence sources to try to get at some of these questions, which I'll share with you over the next few slides. The other question that comes up in the second half of the slide is prediction. Can we use predictive models of any sort to try to predict infectious complications based on underlying disease, comorbidities, or specific agents. Does that help us in the case like this? And I will tell you, spoiler alert, we don't have a whole lot of data to this specific case of transplant and use of biologics in this concept. I mean, it's really an area of unknown. I would also argue in the case of malignancy and other complications, we have very limited data sources, really, although there are some. So let's look at these at high level. This is specifically looking at TNF inhibitors and risk of infection. You can see here at the top of the slide a little bit of what was included in this meta-analysis. And I will, unfortunately, in the interest of time, move to the results, which are essentially that TNF inhibitors were associated with increased risk of infectious adverse events. I think not particularly surprising to many, tuning in who use these agents. Increased any infection, serious infection, tuberculosis, opportunistic infection in that case. And so I think for that reason, in line with what how you all voted, I think TNF inhibitors might be lower on our list for a patient on background, transplant immunosuppression. One might argue increased risk of non-melanoma skin cancer and other things could come up in this concept. This is a paper we just published. In fact, I'm delighted to see it made the cut here in ACR. This is a study looking at specifically, and I have to give a little bit of background context. There has been, partly because of the investment over the years in a safety registry, the SOLAR registry, among other things, some understanding in particular that that ustekinumab has been thought of as a particularly lower risk agent in the setting of infection and other safety concerns among biologics. With that background, this study was designed around ustekinumab as a comparator to other mechanisms of action and drugs in our biologic arsenal. Unfortunately, based on the data set, it does not include P19 inhibitors specifically because of the time frame, but it's looking at claims data. And we specifically looked to ask the question about, relative to ustekinumab, how did other biologics and oral molecules fare with regard to serious infection, hospitalization, and then broken down by bacterial, zoster, and others that are not listed here. And the take-home message is at the bottom, which is that other biologics compared to ustekinumab and apremilast, which is a bit surprising, which I can mention, had a higher risk of hospitalized serious infection. And then you could get a sense, a bit relative to even perhaps each other with that anchor, how serious infections, including bacterial, fell out. You might appreciate that some of the anti-TNF drugs came out on the higher side. IL-17s maybe a little bit lower, but also sort of similar risk ratios to ustekinumab. And then, of course, we don't, unfortunately, have the P19. I can't explain this fully, but one of the thoughts here is, because this is claims data, there is the potential a bit for, confounding by indication, if you will, or a protopathic bias, which is, for example, patients at the highest risk for infection and comorbidities, et cetera, may be given a drug like apremilast because it's thought to be so safe. So these are hard to unpack, and there is confounding potentially in here, but food for thought in our discussion. Similarly, here we have a real world look at serious infection among some of our different classes. Again, I will. This was a retrospective cohort using claims data again in the U.S. And again, I'll unfortunately have to cut to the chase here a little bit in the interest of time, but to say that this was an interesting study in that they looked at a variety of pairwise comparisons among biologic naive versus experienced, and looking at comparisons such as 1223 versus TNF, IL-17 versus 1223, et cetera. And you get the sense, picking this apart again, that there was that some of the risk was numerically lowest for 12, 23, followed by 17, and then TNF. So we start to get a bit of a trend that I think is somewhat intuitive to what we've seen in clinic. Again, unfortunately, P19 IL-23 inhibitors are not listed. One might be tempted to lump them in with the 12, 23, 17 class roughly by mechanism, although it may not be a completely fair comparison, of course, to what we have here. And I would just go to say that there's similar data here with regard to the results. If you look at sort of a broader view of these agents, again, because we're running low on time. So, and this is the SOLAR registry data. Perhaps I'll end with this in terms of infection risk. But this is a really robust prospective observational cohort that's been going on for many years. In fact, there's a second version that will be moving forward around P19 inhibitors and such. But just to say here, the take-home message, this was the question about, are there predictors of infection that we can think about among our patients on biologics? And you can appreciate here the take-home message is sort of on the bottom, which is that increased risk for serious infection was associated, perhaps not surprisingly, with advancing age, with more severe psoriasis, which was interesting, of PGA 4-5, a history of infection and diabetes. So I think there's some intuition there in terms of what might be predictors of serious infection. With that, I'm just going to have a brief mention of this, and I think we won't go on to our, there are two brief cases at the end. I think instead we'll pause maybe for questions. But Philip did mention this at the beginning, and combined clinics, I have the privilege of being in a true combined clinic setting where dermatologists and rheumatologists and trainees are sort of going into a clinic room, seeing a patient together at the same time in, what I would term an ivory tower academic rare model. But I use that, to say that we've seen models around the country that include everything from private practice models where dermatologists and rheumatologists physically come together and see patients. And there was a model like that in the DC, Maryland area for a while that was successful. And then everything in between, all the way through to what I call the facilitated communication model, which is really, identifying colleagues who are dedicated to the care of psoriatic patients, either in the skin or joint arena or other, and making sure that we are just having meaningful facilitated communication around patient care, and making sure that that patients are getting to each specialty in a timely manner, and sort of everything in between. And I will pause for a moment. Philip was kind enough to mention a group called Pac-Man, which he is also quite involved in. And if anyone's interested, it's ppacman.org. There are resources there, including medical record templates, and guidance on how to develop combined clinic models or facilitate communication. And we really do believe that communicating better between the specialties ultimately benefits our patients with psoriatic disease. Because we have about 4 minutes left, I'm going to pause there. And Philip, I think we had a few questions in the chat. I wonder if I'll turn it back to you for any remarks about this combined clinics, and we can maybe move to the questions.
Oh, so let just to make sure that we address Paras Karmachara's questions, and then that gives us a little bit on a few moments for you to wrap up on your experience in clinics. So I'm going to start with her second question first because it's a little easier, and that is, would you recommend a different mechanism of action, for example, IL-17? For a patient with a primary failure with TNF inhibitor? Do you recommend a different approach for patients with primary versus secondary TNF inhibitor failure as in AS guidelines? So I think that's straightforward. If you look at the data, the Kaplan-Meier curves from various European registries or the Corona registry, you'll see that if a patient has a true primary failure with one mechanism, then it makes more sense to move to a second mechanism because that patient may have an immunophenotype immune response that is just suggesting that they need a different mechanism of action. Most often, we are dealing with secondary failures, people who have some degree of response. It may be brief. It may not be 2 years, as many people get. It may be just a matter of 9 months that they get a good benefit, but then it may wane. In that patient, I think it's fair game to potentially go to a second, in this case, TNF inhibitor. And so I think I would include TNF inhibitor along with every other option. And the patient may then, upon hearing about the different choices, say, I think I'd rather go with an IL-17 or IL-23 inhibitor because maybe the safety profile reads a little bit differently, but I would base it on those things rather than on the efficacy. But you're absolutely right. If primary failure, I'd go to a different mechanism. What is your first-line therapy for enthesitis and dactylitis predominant disease? Would you try methotrexate first? So if I address the second part of that question, I would say no, I wouldn't go to methotrexate first, especially if they had enthesitis, dactylitis, and I'm going to add severe spine disease or severe skin disease. I would likely choose either any one of the major categories. I would either choose a TNF inhibitor or I would choose an IL-17 inhibitor, most likely in those situations. We've got fabulous data from the development programs for each of these medicines for complete resolution of enthesitis and dactylitis. Methotrexate has only been recently in the GRAPPA guidelines been thought of positively in treating enthesitis and dactylitis based on data from the SEAM trial in which it was compared to etanercept and didn't do quite as well as etanercept, but nonetheless seemed to work. But I think the biologics are a much more likely way to go with prominent enthesitis and dactylitis. And if I've got a patient in an orthopedic boot in front of me who can't walk to work because of their Achilles enthesitis, then I would definitely go for one of the aggressive biologics that can work in that difficult to treat domain. Joe, back to you.
Thanks so much, Philip. And, I will just take this opportunity to wrap up because I know we're just about at time here. So I want to thank my colleague and friend for sharing the past hour with me. Hopefully you all found this instructive and interesting. Just to recap that we covered axial involvement in PsA and how axial PsA may or may not be a different animal from AS, and stay tuned on that based on Philip's presentation. We talked about comorbidities, including the increased risk of gout among psoriasis or arthritis patients, and we talked a little bit about infection risk as it may relate to some of our choice of therapy around patients at risk for increased infection. And we talked a bit about how combined care might really facilitate the best care of the patient. I think with that, we'll wrap up. And I thank our hosts, and I thank you, Philip. So thank you so much for your attention, and have a good evening.
Thank you.